welcome back everyone. Thank you for tuning in. I hope you're keeping well and safe out there, and thank you for joining us, Professor Ahmed.
It's a pleasure. Thanks for having me, Axel.
No, it's a real honor to have you with us. With this session, with this video, this interview, we are staying in the realm of surgery, but we are now taking our first steps beyond orthopedics to explore other aspects of surgery, and in particular, your specialty and the field that you do. Now, I'll ask you to introduce yourself shortly, but just worth noting that, of course, you are a surgeon with a lot of experience, but also a pioneer in the use of different innovative tools to enhance the delivery of care and the patient experience. I've also seen several notes referring to you as the world's most watched surgeon. So, it's a great honor to have you with us.
It's a pleasure. And again, thanks for having me. I look forward to this conversation.
Well, so before we start, sort of set the scene, if you will, can you tell us a bit about sort of the type of operations that you do and your, I would say, sort of normal day-to-day practice as a surgeon?
So I think things have changed in the last 10 months or so, Axel. That's fairly evident from all the clinical practice you've seen. Before, of course, we're full on working full-time with patients across general surgery. I'm actually a colorectal surgeon. I'm a laparoscopic surgeon, a keyhole surgeon, and I've been working with cancer patients for the last kind of 27 years in my career. And so that's been my specialist area, but also we cover general surgery and also the emergency surgery that comes to the door, for example, things like appendicitis and abscesses, etc. So we cover a wide range of areas within surgery itself.
And of course, I mean, as you say, things have changed, and things are likely to continue changing. But what is your current perspectives on the state of surgery at the moment? And I guess perhaps, while we want to understand how things are currently and how surgery has been affected sort of today and this week, it would also be interesting to gain a bit of an understanding about kind of the framework around how decisions are going to be made over the coming months in terms of different types of elective surgery, in terms of different types of cancer surgery.
Yeah, it's a really good question. I think it's going to be a struggle at the outset. Let me say that. If you go back almost a year ago now, when the pandemic first hit us, we then went into lockdown fairly quick after that. And we had to really figure out how we're going to prioritize operations across different specialties. Cancer, of course, was very emotive. We had to ensure that we mobilized quickly to ensure cancer patients weren't disadvantaged and they were having the operations in a timely manner. So what happened was, of course, is the UK decided to use the private sector for a lot of urgent operations, as well as elective operations, to be able to open the capacity that was there with theatres that were kind of non-COVID, that were perhaps safer environment for elective patients to be in. And we did well. So in London, for example, from about March, April to about August, we utilised a lot of the private hospitals in London to ensure that we gave the cancer patients priority. We also used it for urgent operations from different specialties like orthopaedics and general surgery to ensure that we looked after the patients effectively at the right time. With each lockdown, of course, we have to go back. We open up again between lockdowns, and look, after August, we opened up again. And it's great because the surgical community worked really hard, extra sessions, longer days, trying to make sure that patients got their elective operations. And then some hospitals were up to 80-90% of normal activity. There's great turnaround very quickly. But again, of course, then you change again with a second lockdown and a third lockdown. This lockdown has been particularly hard because obviously with the amount of patients coming through the door, the intensive care, the hospitals are overwhelmed with the patients with COVID. At the Royal London where I work, for example, we have about 580 beds. About 480 are now taken by COVID. That has impact because our patients require major surgery, some require intensive care support, HD support and recovery. We've got to make sure we have a clean zone compared to the dirty zone for other patients. So that becomes more and more difficult. So elective surgery got cancelled as a consequence of those problems. So as we go back forward now, as we open up again in a couple of months' time, we have to think, okay, now how do we establish elective practice again? How do we select patients? How do we prioritize people? At the moment, all cancer patients are still going ahead with their priority 1, which is urgent emergency operations, as well as priority 2, which is within 28 days of the diagnosis. So we're still ensuring that we're trying to keep up the operations for those that are most disadvantaged. But the problem as you go forward now, Axel, is this. It's the maths behind it. If you go look at the UK as a whole, we perform about 50,000 elective surgical operations per month, okay? So you add that up and it becomes a bigger number and a bigger burden. So I think as we go forward, it's about planning. It's thinking about what time scale is going to be available. It might take a year or two before we get back to some kind of normalcy. We're going to have to make choices around which patients require the surgery. Remember, it's also about patient empowerment. They may decide, some patients, not to have the operation for the time being. They can delay things safely, and that's for us to judge effectively. So it's safe for them to delay if necessary, or proceed with a more urgent operation for them. And those discussions will take place on an individual basis as we go forward. The challenge is for us as a community, as healthcare providers, to figure out what does that new normal look like? How do we use the theatres more effectively? How do we use the cadre of surgeons in a better way? How do we redistribute the workforce accordingly, as we've done with the COVID?
Yeah, yeah.
And those are the challenges we have going forward, Axel.
Yeah, I mean, absolutely. So, I mean, it's just, while we're facing these very, very difficult challenges and difficult decisions, there's some encouragement in how different parts of the healthcare community have banded together and come together, private hospitals and NHS hospitals and different specialists all pooling together the resources and their time and their skills to tackle these challenges. But as you say, the problem is progressing with each month, and each lockdown poses its new and additional challenges. You mentioned about the different priorities for different types of procedures. Could you expand on that a little bit, perhaps with some examples on priority 1 and priority 2?
Yeah, so look, when we, this is particularly for cancer, I'm of course discussing. So if you think about the cancer pathway, when patients present with symptoms or referred through any cancer pathway, we have certain dates. We have a 31-day pathway and a 62-day pathway. The first about diagnostics, but so by 31 days, everyone should have the diagnosis confirmed. And by 62 days, we should commence treatment. So that's around the pathway of actual patients with cancer who present with symptoms. Secondly, we have this whole issue around the urgency of surgical operations. Priority 1, essentially, it covers the patients that have immediate risk. Either they come through emergency, and for my case, for colorectal cancer, it could be bowel perforation, obstructions, or something really urgent, immediate, or those that need urgent operation because symptoms are becoming overwhelming, or they may have further complications if we don't do them. And that has been done immediately on admission. The priority 2 is basically patients can wait, and we do those within 28 days, which is another target for us. So that's priority 1 and priority 2. Priority 1's fine, that we accommodate, we do those operations as we have been for the last 10 months. Priority 2 is the difficult one, about how do you use resources effectively to ensure that patients do not have a delay, which may affect their outcome. It will also affect their well-being, knowing that they've got cancer, they want operations, yet we're deciding to delay that a little bit further. So it's managing the expectations, also managing the resources appropriately so that we can operate on many of these people as possible without delaying or affecting their outcomes.
Yeah. And what would your message be to someone who might be out there now watching this, who is facing perhaps some uncertainty or perhaps even a definite delay with planned treatment? What can I, as a patient, do to sort of get that sense of empowerment, or to try to understand what's going on and to try to gain some kind of agency over my situation?
So let me reassure the public, first of all, we are here to help. We are here to support. We're here working, and we'll do operation as best we possibly can, as we were doing before the pandemic. So you are our priority. We have enough capacity for diagnostics so that you will get diagnosed early at the right time. And please do come to the hospital. Do not be afraid. Have the appointments, whether it's virtual or face-to-face. Make sure you get your tests done so that we can diagnose you as quickly as possible. And that facility is still available for everyone. So don't be afraid. We're not rationing care. We're still managing it as best we possibly can. In terms of operations, we're very sensible. We're making sure we protect you from having adverse outcomes, also from delaying your surgery. We are here to ensure that you have a timely operation with the right people at the right time. That's what we're here for. And we'll do that effectively. So patients are getting treatment. they are getting diagnosed and with good outcomes. So it's important to us to reassure the public that the service is still running as it was before, but we've just had to be more sensible about how we manage the pathways, etc. Of course, what we've done in the hospital is we've made sure that if you're coming for an operation, you'll be selected in different pathways so that you go to the clean part of the hospital, that we'll try to be COVID-free. We did a lot of testing to ensure that you're as safe as possible to reduce the chance of you having a bad outcome. So look, we're here, results are good, we're here to support, and the NHS is still supporting all patients that come through the front door and very much prioritizing patients with cancer.
Yeah, I think that's an important and reassuring message that in some ways the experience of care at present will be somewhat different, but the care is there, it's happening. And for those who might be watching this, who have received a date for surgery or an investigation and are a bit wary of going into a hospital in the current climate, you mentioned some of the steps about clean zones and so on, but can you tell us a bit more about the steps that are taken or what one might expect as a patient in the current climate?
So the patient, first of all, may have a face-to-face. Just as likely they may be offered a virtual consult, either with a telephone conversation or indeed telemedicine, a video like of being on a computer. So we're changing the way we're speaking to our patients. We can't accommodate everyone face-to-face. So that's a change from previous models where it was always face-to-face conversation. They get lots of follow-up advice. They have telephone numbers and people to contact if necessary. Then, of course, when they come into hospital, prior to coming to hospital, they will have their usual checks, blood tests done, a pre-admissions check, as we have done before, and that's all face-to-face generally. They'll also have some COVID tests done to ensure that before they come in, for 2-3 days before, they have the test and they are clear of COVID. And that gives a signal that it's quite fine for them to have the operation. We don't operate on patients who are COVID positive unless, of course, they have an emergency procedure. So we take precautions to protect our staff, to protect the patients, more importantly, to ensure they have the best outcome. So although the pathway has changed slightly, our kind of emphasis is still on patient safety to ensure that we do the best we possibly can, given restrictions. The hospital itself, just as an example, when you come in, it's different. You won't be able to bring your family along with you. You won't be able to have those conversations and have them by your bedside. We want you to come on your own. You'll then go to the ward, which is separate to the rest of the hospital managing COVID, and we make sure that's as clean as possible so you don't transmit or get infected by COVID. So that's absolutely safe. You'll then have your operation as planned. You meet the surgeon, you have the operation as would happen before. Then we, of course, support you post-operatively. We have a separate area in terms of recovery. It could be high dependency intensive care, but it's different to what's offered for the COVID patients. It's separate. So it's dedicated to surgical patients. That means that we do our best to ensure that the environment is clean as possible, and the patient is safe as possible. And we've done well. I think we have great outcomes so far. It has changed the way we manage our patients, but it has affected the outcome.
Okay, that's also quite reassuring to hear. And I know we've had a few questions sent in from people who do have procedures booked in and who have either read in the news or heard rumors and for whatever reason are a bit concerned that they might end up spending less time in hospital than one would otherwise. What would you say to that kind of concern about being, the idea of being sent home perhaps sooner than one would normally, and then also without perhaps access to a sort of normal level of support in the community as well?
Yeah, it's a very good question. Look, I think that we don't send patients home unless they're ready to go home. That hasn't changed. We still make the clinical decisions based on when patients are best able to go home and recover quickly. So that hasn't changed at all. Obviously, it's great to be away from a hospital. You don't want to be anywhere near a hospital if you can afford it, right? And so we always have this thing called enhanced recovery, which has been happening for many years, Axel. We try to push patients out much faster, to recover quickly, to mobilize quickly after operations. Imagine 20, 30 years ago, a patient would be in hospital for 10, 20 days after a major surgical operation. Now it's a matter of 2 to 5 days, if that. So we've moved on anyway in terms of accelerating people's experiences and moving them out of hospital to community quickly. Community is still there. We still have GPs, they still see patients face-to-face, they still have consultations, still have telephone services, and we're also available for any post-operative complication. They can come back in or make a phone call. We're still available to ensure that their quality of care throughout their episode is still much the same as much as possible. Of course, it can't be entirely the same. There's some differences, it's changed the way we interact, but we have the support necessary to ensure those patients, when they're sent home, are safe as possible.
And from your point of view, we've talked a lot about how the experience has changed from the patient side. How about from your point of view as a surgeon? What are the sort of most significant changes in the day-to-day practice?
I think we just got to be more aware of ensuring that we do the right things appropriately for our patients. We have to adapt the way we manage, the way we do our virtual clinics, for example, the way we talk to people, making sure they're reassured, making sure if we break bad news, it's done appropriately with nursing support in the room. So doing this telephone consultations, the virtual clinics, has been a change from our normal practice. And actually, overall, it's been okay. The feedback so far has been as good. It's effective. People, of course, always prefer face-to-face, but our patients are very supportive of the fact that this needs to move on and we need to adapt, and actually have been fine with the way we've conducted ourselves in the clinics and also in terms of their support going forward. So that's changed for us. The other thing that changed, of course, sometimes when you're emergencies and you have to wear PPE or we have to wear the full protective clothing, that's a bit difficult sometimes. Imagine being in PPE for many hours at a time in the operating theatre. It can be difficult. You're very sweaty, it's hard work, and not something we're used to in that sense. So I think the way we have been operating those conditions has been a little bit tougher, but we've overcome some of those problems. We know now what to do, how to manage the conditions and the environment of operating theatre. So actually, I think we've learned a lot and offering, I think, a really excellent service, not just in London, but throughout the UK. I've seen really good quality services still persist despite the pressures on the system. And of course, as doctors and healthcare workers, we've also to adapt in our new environment. Some of us have been redeployed. Our junior staff have been redeployed to maybe intensive care or A&E. So we're now working with a different skill mix there. Our workforce is more flexible in working in different parts of the hospital. And so we also have to be flexible as consultants to ensure that we provide quality care 24 hours a day with different personnel. And I think that's been the beauty of the NHS, how everyone's come together, reskilling if necessary, upskilling if necessary, working as a team across different sectors to ensure that we have enough staff at each point to deliver the care that's required. So, for example, I did a shift on nursing as a nurse on intensive care only a couple of weeks ago because there was a cry for more doctors or any healthcare workers just to support the nurses who were really struggling with the numbers of cases coming through the door over Christmas and New Year. So we all decided to get together, we did our shifts, and we were just supporting, helping where we could. I think that showed the real, the value of this wonderful healthcare system called the NHS, where together over the last 10 months, we've increased ICU capacity 200% by the first pandemic, for the first lockdown, and 300% for the second lockdown. We've ensured we've had enough capacity, enough support, healthcare workers to give patients the best care. We've redistributed the workforce appropriately with good training to ensure that, again, people are being used appropriately in the right spaces. And the goodwill, of course, is always there for the NHS, which it relies on. And we've seen amazing courage, we've seen amazing dedication of all the frontline workers managing not just surgical patients, but all the patients that come through our hospitals.
Yeah. And the NHS will continue to learn and continue to adapt to the changing situation that we're in. But as we look, let's look forward now. Let's look beyond the pandemic to happier times when we can return to that sense of normalcy. What do you think will be sort of the remaining changes, and perhaps if one could say the sort of the legacy of COVID in terms of how it might change or reshape or rethink the practice of surgery?
Yeah, great question. I think undoubtedly it will change. I'm hoping it will change as well. We've become more digital, Axel, haven't we? We've become more understanding of technology and innovation over the last 10 months. What the COVID pandemic has done is accelerated change. It's compressed time almost. The innovation that we've seen over 5 or 10 years has been squeezed literally into about 10 months. People's perceptions have changed. People understand different ways of working. Who would have thought, about a year ago that we would be spending time with our patients with cancer via telephone or telemedicine? It would be unheard of. But now we're adapting. We're seeing that our patients also engage on a journey with us and understand new ways of working. So I think it'll be a reset, and we'll be pushing forward. What about surgery? Look, there's no question. We'll be learning about how to prioritize patients more effectively, how to ensure more safety going forward. And we've learned that from this pandemic. We'll also look about how we come back stronger. How do we use our resources in a different way? How do we ensure it's more cost effective? How do we use technology to move forward? I can see in the future, a lot of clinics now will not be done face to face. Over the pandemic, the first 4 to 6 weeks, telemedicine was increased by 7,000% in many institutions. So we've had a lot of these spaces in the hospital where you have outpatient clinics. They've had the experience, Axel. I sit in clinic and we have a lot of patients coming through the door. They're in a jammed waiting room and they're delayed by an hour and a half, 2 hours. They park their car somewhere, paying some money for the car park charges, and they're not being seen adequately because there's so many patients to be seen. That's not, I always thought that wasn't right. It was a poor way of managing patients, and the experience, it was dreadful. So now, of course, those outpatients are going to be empty. There'll be only a few patients seen at the right time. Most will be elected to see it in their own time on some kind of video platform, which gives the patients, I think, more empowerment. It's at their discretion. It'll be at their time. It'll be more appropriately managed. Yeah, they won't have to come to hospital, which is great news. That saves money in the long term and offers better quality and experience for the patient. The surgeons themselves isn't going to change, but now we're seeing remote working. So now we're seeing this kind of, for the surgeons, use of remote technologies to teach people remotely. So for example, as the teacher in our medical school, I used to be the associate dean, of course, we had to rethink how do we bring students into the operating theatre or into the clinical environment. I've used augmented reality. We use a HoloLens system where I can relay information in real time. I'm on the ward seeing my patients doing ward rounds, and the students themselves or trainees are in a lecture theatre across the road, all social distance, and can see what I'm doing, communicating, teach them in a different way. So even the student education will change into more hybrid models. We don't need as much bricks and mortar in the future. We don't need to invest as much in that. We can now do a hybrid model, a virtual learning experience, plus face-to-face clinical contact where it's necessary. So the whole mood would change. The whole way we deliver education in the future will become more virtual. And I think this year has shown us that that's where society is heading towards. And also the needs are going to be much greater in the future.
Yeah. Fascinating. Well, Prof, thank you so much for joining us for this session and giving us a walkthrough of some of the very difficult challenges that we're facing and the difficult decision making involved in that, but perhaps also a little bit of a crack and a look at a little bit of light towards the future as well, of how things might be. You know, some of the positives that are coming through this, people coming together, the NHS as ever standing strong and resilient, and some positive change coming out of it in terms of delivering care in the best way possible to surgical patients of the future. Is there anything else you'd like to add before we sign off this session?
No, I'd like to say that we've done really well in the last 10 months, under a lot of pressure, a lot of stress, but actually we've managed the workload well, patients are getting good service. I don't want the patients to be worried or concerned. And I really want them to tell them basically, if you have referral, please come and see us. Don't delay it. If it's potential diagnosis of cancer or something more urgent, please come. Please have your diagnostics, your tests. Make sure you come and see us. And don't be afraid. We'll be here supporting you. We won't delay your operations. We'll be doing them in a timely manner. But we are here to help and serve you. So don't be afraid or concerned that we're going to be making rational choices about your care. We're going to treat you as we were before to ensure you get the best standard of care.
Yeah, absolutely. Well, thank you so much again, Prof. And thank you everyone for watching. If you'd like to find out more on these topics or see more of Prof. Ahmed's videos, there'll be links below this. As ever, let us know what you think about this video. If it sparked any other questions, do send them in and we'll dig into it in an upcoming session. In the meantime, everyone, stay safe out there, keep up the good work, and bye-bye for now.